Initiative for Health Accountability and Transparency, welcome you to continue professional development course on primary healthcare renewal for optimal performance. This is module 3, and this module is on primary healthcare in Nigeria, current situation and persisting challenges. The outline of this module include the learning objectives, the background, the current situation and realities, the persistent challenges, and the conclusion. On completion of this module, participants will be able to understand the rationale and purpose of PAC in healthcare delivery, explain the current situation and realities in PAC in Nigeria, discuss the difficulties, and also identify the challenges in primary healthcare delivery. The Basic Health Service Scheme of 1975 was the first attempt at developing community and people-oriented health system in Nigeria. Remember that the health system that was inherited at independence was purely curative. The goals and the objectives of BHSS were not attained due to lack of dwindling economic fortunes and failure to adhere to the implementation plan. Note that as a result of economic recession at that time, the parameters on which the national economy was based did not favor continuation of the scheme in terms of adequacy of the required resources. From 1986 to date, Nigeria has embarked on major efforts in reforming its health system with the government technical agencies, development partners, and several other stakeholders playing significant roles. There have been landmark periods in PAC development, including the PAC rebirth that happened between 1986 to 1992, during which the median national health policy of 1988 was articulated with primary healthcare as the cornerstone. A number of provisions in the national health policy affirm the centrality of primary healthcare to the achievement of an effective and efficient health system in Nigeria. Let us take a brainstorming exercise. Can you list some PAC development milestones in Nigeria? There are a number of significant PAC development milestones in Nigeria. We've mentioned the BHSS, which was the forerunner of primary healthcare, meaning that some form of primary healthcare had already taken root in Nigeria before the Alma-Ata Declaration happened in 1978. But there's also the LGA Focus Acceleration of PAC, which began with 52 local government areas in 1986. It will be recalled that by 1990, all the local governments in Nigeria were already implementing primary healthcare. We should not forget about development of national health policy in 1988 with PAC as the foundation of the national health system. There is the devolution of primary healthcare to the local governments in 1992, which transferred all responsibilities, including the staff of primary healthcare, from the state to the local governments. Establishment of National Primary Healthcare Development Agency happened in 1992. The National Program on Immunization, NPI, was established to show up immunization in 1996. There was also the commencement of the process of primary healthcare revitalization with the adoption of the World Health System in the year 2000, and also the merger of MPI into MPACDA, which happened in 2007. All these are very significant milestones that have affected primary healthcare development in one way or the other in Nigeria. Looking at the purpose and the rationale of primary healthcare. In primary healthcare, the people are the targets, the determinants, and the beneficiaries. It is often described as health of the people, by the people, and for the people. It is the first level of contact of individuals, the family, and community with the national health system, bringing healthcare as close as possible to the people where they live and work. Let us look at the PAC train, and showing that primary healthcare is the platform for integrated services. You can see the PAC train with all the wagons carrying all the PAC services moving towards health for all. Integration is very, very fundamental to delivery of an effective and efficient primary healthcare. Continuing on the purpose, primary healthcare is the only system of healthcare that addresses the basic health needs of the people in a way that guarantees equity and equality. PAC is central to delivery on equity, social justice, solidarity, universality, accountability, and responsiveness to the needs and the demands of the community and the people. Let us take another brainstorming session. The period between 1986 and 1992 is often referred to as the golden period in primary healthcare implementation. What were the success factors? The success factors primarily include the unitary health system across the country. This was a period that the country was under the military regime, and the kind of command system that the military regime runs allows for an operation of unitary health system. So this is one of the enablers that contributed to success that was recorded during this period. There was also the willingness of states and LGAs to implement primary health care. LGAs had to meet laid out conditions before they were enlisted in the program and given the federal support. There was sustained federal financial support in form of grants to the willing local governments. They have also sustained technical support from the states and also the federal government. And let's not forget that there were also training institutions like the universities and partners like WHO and UNICEF that were providing support to selected local governments. Funds were released based on performance and achievement of set milestones. All this contributed significantly to the successes that were recorded during the period under reference. The current situation and the reality of primary health care. What is your view? There is stagnation and underperformance in many spheres of health development particularly primary health care, such that if health is indeed wealth, Nigeria is indeed a very poor country. Using health as a basis of measurement means we are one of the poorest countries in Africa. According to WHO Afro-Regional Report 2014, Nigerians' maternal mortality is only better than that of Chad, Niger, South Sudan, Liberia, Guinea, Congo DRC, Central African Republic, and Sierra Leone. The health system is suboptimal, and this report, bank report, is about improving PSC delivery in Nigeria in a report that came out in 2015. Despite considerable investment in the health sector over the years, availability of functional health facilities still presents significant obstacles. Majority of health facilities are not functional at optimal capacity in providing quality care, especially in the LGA and the ward levels. The WHO report indicated that the condition of PSC infrastructure often show decaying infrastructure and do not offer all the basic health services. The report also indicated that close to 50% of facilities do not have required health personnel, equipment, supplies, and pharmaceuticals needed to effectively deliver services. And about 2 out of every 5 health facilities have leaky roofs, broken windows, and/or doors. And less than 3 out of every 4 facilities do not have waste disposals, electricity, fridge, ice box, or toilet. The report also indicated that large percentage of facilities do not have basic pharmaceuticals on stock, and only about half of the PSC facilities have vaccines on stock. There are major constraints in the referral system, as only about half of the referred patients have easy communication with the referral center. Looking at the poor health outcomes, maternal, newborn, child mortality remain high, and there is suboptimal routine immunization coverage and persistent transmission of WPV in few states as at that time. Also, according to WHO Afro-Regional Report in 2014, life expectancy at birth was 54 years, and this was 4 years lower than 58 years average for African region. A maternal mortality ratio was 576 per 1,000 live births against 500 per 100,000 live births for African region. Infant mortality rate was 78 per 1,000 against 63 per 1,000 for African region. Current situation and realities. What is your opinion about current situation and realities of primary healthcare in Nigeria? First is suboptimal health system. Let us look at report of the World Bank Improving PSC Delivery in Nigeria 2015. It says that despite considerable investment in the health sector over the years, availability of functional health facilities still presents significant obstacles. Majority of health facilities are not functioning at optimal capacity in providing quality care, especially at the LGA and ward levels. The World Bank report indicated that the condition of PSC infrastructure often shows decaying infrastructure and do not offer all basic health services. That close to 50% of facilities do not have the required health personnel, equipment, supplies, and pharmaceuticals needed to effectively deliver services, and that about 2 out of every 5 health facilities have leaky roofs, broken windows, and/or doors, and that less than 3 out of every 4 facilities do not have waste disposals, electricity, fridge, icebox, or toilets, and that large percentage of facilities do not have basic pharmaceuticals on stock. Only about half of the PAC facilities have vaccines on stock, and that there are major constraints in the referral system. Only about half of referred patients have easy communication with the referral center. Let us look at the issue of poor health outcomes. Maternal, newborn, and child mortality remain high, and there is also suboptimal routine immunization coverage and persistent transmission of WPV in few states as at the time of this report. Let us look at the issue of poor health outcomes. Going by the reports of National Immunization Cluster Survey and the Multi-Cluster Indicator Survey, maternal, newborn, and child mortality remain high, and there is suboptimal routine immunization coverage in many states. There is stagnation and underperformance in many spheres of health development, such that if health is wealth, we are indeed a very poor country. Using health as the basis of measurement means we are one of the poorest countries in Africa. According to WHO Afro-Regional Report 2014, Nigeria's maternal mortality is only better than that of Chad, Niger, South Sudan, Liberia, Guinea, Congo DRC, Central African Republic, and Sierra Leone. Continuing with the report, life expectancy at birth was 54 years, and this was 4 years lower than 58 years average for the African region. The maternal mortality ratio was 576 per 100,000 live births against 500 per 100,000 live births for African region, and infant mortality was 78 per 1,000 against 63 per 1,000 for African region. Under 5 mortality rate was also high for Nigeria at 124 per 1,000 against 95 per 1,000 for the region. It is estimated that 1 out of every 7 to 8 children dies before his or her first birthday, and 1 out of 6 before her or his 5th birthday in Nigeria. There are an estimated 3.5 million people living with HIV, and this is one of the highest numbers of infected people in the world. Nigeria also has the 4th highest TB burden in the world according to experts. There are many drivers of the poor health outcomes, and this includes gross inequity in distribution of health resources, utilization, and health outcomes. There's inefficiencies in service delivery from fragmentation and vertical programming, and there is also weak infrastructure and poor quality of care challenges. Let's look at the difficulties and persistent challenges in PAC delivery. Primary healthcare sector in Nigeria has limited capacity to meet set policy goals and objectives. It is characterized by insufficient coverage of essential health services. The challenges are primarily systemic and are responsible for suboptimal performance of the health system. The difficulties and challenges range from political, strategic, technical, operational, and community issues, and can be discussed under broad categories such as inadequate political commitment, poor governance, lack of funding security, dysfunctional deteriorating infrastructure, poor technical and management capacity. There is also lack of functional integration, both vertical and horizontal, and lack of effective interconnectivity between primary healthcare and higher levels of care. Note that the vertical approach to program implementation has become the norm in Nigeria. There is also the issue of disjointed engagement of the private sector in delivering public health without an effective regulatory authority by the government. There is also the issue of knowledge brokering, which has to do with poor linkage of evidence with goal setting and intervention strategies. There is the issue of inadequate political commitment. In most countries, people rate health as one of their highest priorities, behind only economic concerns such as unemployment, low wages, and high cost of living. For many nations, access to health and healthcare has become synonymous with social progress and social justice. Health has therefore become a critical macroeconomic and political factor that ought to be a political priority as governments try to meet people's expectations. Unfortunately, this is not often the case, particularly in developing countries. In Nigeria, health is not well articulated and reflected in the national political agenda. The manifestos of the political parties in Nigeria does not address health sufficiently, and only sustained political commitment by all governments will ensure availability of functional infrastructure, adequate human resources, and sufficiency of appropriate supplies and commodities, which are all essential for delivery of quality services. Let us look at the issue of the weak governance system. Weak governance structures and appropriate policy constitute strategic threat to primary healthcare development in Nigeria. Incomplete devolution of authority from the national to the states and from the states to the local governments as regards primary healthcare implementation has remained a significant obstacle. In the country's physically decentralized federal system of governance, health is one area that all three levels of government has responsibility and is often said and assumed to be on concurrent list of public services. Poor capacity in managing and planning resources and implementation at all levels is a significant bottleneck. The 1999 Constitution does not explicitly deal with health. However, the National Health Policy laid responsibility of providing health services, and hence graduated health services are organized and provided at the three levels of governance. Fragmented responsibilities and misalignment of structures and responsibility in the health sector is a significant constraint. The federal government is responsible for tertiary care, the state governments provide secondary care, while the local government takes charge of the primary health care. Local government level is the weakest link in the federal governance chain, and this level is holding responsibility for the most important aspect of health service provision. The necessary strategic and technical supports by the states and federal levels are often lacking, or sometimes provided but insufficiently. There are often defaults in the discharge of regulatory and coordinating functions. Weak governance system is manifested by uncoordinated partnerships and consequent lack of effective program coordination at the national and state level. There is also inadequate regulation of the private sector, including the traditional medical practitioners, which provides substantial services to the population. Inadequate funding and the funding barrier is another very significant challenge. The federal, state, and local government in Nigeria are not allocating or spending enough to address adequately the health needs of the population. In 2001, all the African heads of governments pledged in Abuja to allocate at least 15% of their total national budget to health. This commitment is worldwide known as Abuja Declaration. By 2010, Nigeria had not met this target, and today, Nigeria certainly has not met target. And all the 6 African countries, Liberia, Malawi, Burkina Faso, Djibouti, Botswana, and Rwanda, that have so far made the target are poorer than Nigeria. The World Health Organization has recommended that for countries to move towards universal access to health services for their citizens, they must reduce the proportion of people who pay for health service at the point they need them. Unfortunately, in Nigeria, out-of-pocket payments are still the most common form of paying for health services. It is responsible for up to 70%. And as a result, those who cannot afford to pay when they are ill are denied services. Insurance coverage in Nigeria is still less than 10%. There is dysfunctional and deteriorating infrastructure. Access to quality health services requires adequate and functional infrastructure. Like we have pointed out earlier, based on the World Bank report, there are issues of dysfunctional and deteriorating infrastructure almost everywhere. Though there are significant investment expansion of healthcare infrastructure at all levels, many are in poor state, as highlighted earlier. There are about 30,000 primary healthcare facilities, and this represents close to 90% of all facilities in Nigeria, and also close to 4,000 secondary level facilities, represent about 12% of all health facilities in Nigeria. The tertiary level facilities represent only 1% of all health facilities in Nigeria. Based on the Federal Ministry of Health Directory of Health Facilities in Nigeria 2011, 66% of all the facilities in Nigeria are public owned. One of the significant challenges is multi-tier health system and lack of functional integration. The 3-tier health care level, namely primary, secondary, and tertiary, are not functionally integrated. And like we mentioned earlier in the last module, the existence of 2 separate governance structures for primary and secondary care is a significant hindrance and constitutes a grave challenge for functional integration, particularly in the LGA health system. The state should have a unified health service, with secondary facilities being the hub of the state health service and the primary health care being the spoke. The current situation where secondary care is managed by state hospital boards, while primary health care is managed by the state PAC agencies, will not promote functional integration. Let us look at the issue of inequalities and inequity in health. Poor access to healthcare is apparent and increasing. Poor and rural populations in the northeast and northwest of the country have worse health outcomes. For example, child mortality is twice as high in the northwest compared to the southwest. And also the proportion of underweight children is highest in the northwest and lowest in the northeast, and it's also higher in the rural than in urban areas. All these are significant. Immunization coverage is lowest in the northwest and highest in the southeast. Similarly, looking at social economic factors, 58% of children in the highest wealth quintile are fully immunized, compared to 4% in the lowest wealth quintile. Let us look at low quality of health services. Not only is the coverage of basic interventions low and inequitable, evidence suggests that the quality of care provided is inadequate. The World Bank funded Service Delivery Indicator study found out that many health workers perform poorly on standardized tests of knowledge and lack the skills to effectively treat common and important ailments in children and mothers. The SDI results indicated that Nigeria does less well than other large countries in sub-Saharan Africa. The low level of quality of health service is responsible for lack of confidence in service delivery, particularly at the primary healthcare level, resulting in poor utilization of health services at this level. Looking at human resource challenges, maldistribution, poor mix of the different cadres, and lack of performance management lead to inefficiencies in the use of existing staff at hospitals and facilities. There is also the issue of industrial harmony. Industrial harmony is yet to be the norm in the medical and health professions in Nigeria. Information from Nigerians Human Resource for Health Strategic Plan of 2008 shows that 88% of the doctors practicing in the country work in hospitals, most of them, about 74%, in private hospitals, with only about 12% in private or public sector PAC facilities. This is certainly a huge challenge. Many PAC facilities do not have medical officer. Many more do not have nurses or midwives and have to rely on low-level professionals, primarily community health extension workers. Migration outside and within the country, poor motivation, and differentials in condition of service contribute to these shortages. Another significant challenge is provider-focused rather than client-focused health system that is run in Nigeria. Nigerian health system is focused more on health providers than the people. It means is that it's focused more on the supply side than the demand side. Frequently, discussions on health system issues is usually about the availability of health facilities, equipment, drugs, and healthcare workers, with little attention to responsiveness of the system to the needs and or expectations of the consumers. There are no systematic processes for assessing the people's needs and satisfaction with services, ensuring patients' rights and responsibilities, and addressing complaints. The lack of emphasis on the people reflects in the poor attention given to health promotion and prevention interventions, which could have reduced the number of people needing expensive hospital-based care. The lack of emphasis on the people reflects in the poor attention given to health promotion and prevention interventions, which could have reduced the number of people needing expensive hospital-based care. The way forward for improving primary health care. Undoubtedly, PAC in Nigeria needs a revolution to restore faith in primary health care services. It is time to unleash new policy and strategic directions. Looking at policy and strategic options. This subject matter will be dealt with in Module 5. Let's take an assignment. In what ways does the current situation and realities and persisting challenges affect primary healthcare service delivery and health outcomes? This should be an online submission to be marked CPD PAC assignment of not more than 500 words, and they are both issued to hihealthnigeria@gmail.com. Let's not forget the vision of the great leader and icon of primary healthcare, Professor Oliko Ransom Kuti, Honorable Minister of Health, for Nigeria. Let us draw a conclusion. It will be impossible to achieve national and international health goals, including the Sustainable Development Goals, without a functional primary healthcare system and effective services. New policy and strategic options and directions are required to build functional institutions, improving governance for health, infrastructure, logistics, service delivery, developing evidence-based state health strategic development plans, and aligning policies, priorities, and perspectives among policymakers and key stakeholders. Call to service. The role of primary healthcare in the national health development cannot be overemphasized. Putting primary healthcare back on the national agenda is a task that must be done. Our dream for a strong health system and better health outcomes will remain a dream unless we work for it. To work for it, we need a greater understanding of the current situation and persistent challenges in primary healthcare. We need to build strong leadership, effective management, and transparent governance.